Thank you. It's a pleasure to be here. It's actually my first time in Iowa City. Actually, it's my first time in Iowa as a state. So I am very pleased to be here to talk to this group. And before I start my talk, I just want to make a couple of comments. One is I want to present this lecture from a headache physician standpoint, because headache physicians are commonly involved not just in management of headaches in patients with Chiari, but even sometimes in determining whether surgery may actually be indicated. So that's the first comment. Second comment is that headache doctors typically don't know very much about Chiari malformations. I've been in the headache field now for over 30 years, and we've had one lecture on Chiari malformations at any of our educational meetings. I mean, it's really absolutely extraordinary, despite the fact that Chiari patients are often seen in headache clinics quite commonly. So I'm going to talk about headaches in patients with Chiari malformations. So those are my disclosures, but frankly, none of them pertain to this talk. The objectives are as follows: to describe the types of headache disorders associated with Chiari 1 malformations and their treatment, to discuss the pathophysiology, or at least the theorized pathophysiology, because frankly, in a lot of these situations, we don't know for sure the pathophysiology. And finally, to describe the response of typical and atypical headache disorders to intradural and extradural Chiari decompressions. Now, this is just very, very simple, but given that Chiari 1 malformation is diagnosed primarily by tonsillar herniation, I will tell you that headache doctors look at this a little bit differently. We don't assume that just every tonsillar herniation is a Chiari, even if it's greater than 5 millimeters. And so that's the first concept. Second thing is that headache has been mentioned numerous times already today, is the most common symptom in patients with Chiari malformations. In fact, in this one study, 93% of patients had headache, as compared to like neck pain or shoulder pain in 75%, back pain 40%, et cetera. So a headache is the most common symptom in Chiari malformations and a common reason for us seeing these patients in our clinics. Now, to me, what's interesting is this is just one explanation of the various symptoms, or at least it tries to assign what the pathophysiology is to the various complaints in Chiari malformations. And they list the Valsalva or strain-induced occipital, cervical pain or headache disorders under CSF obstruction. And I think that probably is true, that's probably the main etiologic factor. But I will tell you that if you have brainstem compression, you're compressing cranial nerves, which is category number 2. I see that headache is not listed, at least in this table under that I could see that could be another mechanism as well. And there could frankly be others as well. So what are the causes of tonsillar herniation? I mean, many of us in the audience know these, but obviously Chiari malformations one, cranial settling is another one. And just looking at this from a headache standpoint, I've often wondered whether a Chiari malformation in the setting of cranial settling is different than a Chiari malformation with a small posterior fossa. So that's just kind of a general comment, and maybe people can comment on that at the end. Tethered cord, lumboperitoneal shunts, intracranial neoplasms, craniosynthosis, and then finally these things called pseudochiaris. And this is probably what interests headache doctors the most, is whether the tonsillar herniation could be due to intracranial hypotension with brain sag, or whether it could be due to intracranial hypertension as well, that can also cause descent of the cerebellar tonsils. So that would be what we would look at. Now, what's interesting is if you look at the natural history of Chiari malformations, I mean, it is not uncommon for us to have, patients with tonsillar descent. And many of them have headaches, and you can argue whether the headaches are related or unrelated to the Chiari malformation and so forth. But typically in small studies, asymptomatic patients usually remain asymptomatic. However, if they're symptomatic, about 37 to 40% of those with cough headache, which is thought to be due to obstruction of CSF flow, actually improve over time. So cough headache may improve, at least in a minority of people. 89% improved, nausea was improved, and even ataxia and sensory disturbances, kind of the more hard neurologic findings, mostly from brainstem compression, actually tend not to improve. Now, this is interesting to me, is that this is just a headache doctor's list of indications for Chiari decompression. Obviously, one would be symptomatic Chiari, but what's interesting is many papers say headache alone is not indicated, is not an indication for surgery. So I think that's an interesting concept. You looked at Syringomyelia, obstructive CSF flow, progressive neurologic decline / brainstem compression, chronic sleep apnea, mostly central sleep apnea as a result of brainstem compression, and then failure of conservative management, which could mean almost anything. So let's talk about headache attributed to Chiari 1. So these are the International Classification of Headache Disorders. This is kind of our Bible for diagnosing headache disorders. And they basically say that to have a headache attributed to a Chiari malformation, you have to first have to have a Chiari malformation, or at least 5 millimeters of tonsillar descent. And the headache has to develop in temporal relationship to the Chiari. I don't know how that could possibly be defined, or the headache has to resolve within 3 months after a successful Chiari decompression, which is probably more likely for us to make a diagnosis of that. And the headache has one of the following characteristics. So it resembles what we call high pressure headaches. So the headaches tend to be precipitated by cough, Valsalva maneuvers, worse with exertion, sometimes worse with sexual activity. It tends to be occipital or suboccipital in location. And it tends to be rather short-lived. This is the classic Chiari headache, so it just lasts less than 5 minutes. But I will tell you that usually there's this type of headache along with many different headache types within Chiari patients. So if you look at the literature in terms of response to Chiari decompressions, they kind of divide the headaches up into what they call typical headaches, and they would define typical headaches much like I just described, the cough headaches, the exertional headaches, the Valsalva-induced headaches, and atypical headaches. And you can see that 55% of the time, at least in this series of patients with Chiari, they have typical headaches, but about 30% of the time, they have atypical headaches. And you can see the graphs there. And if you look on the right, you can see that most of the atypical headaches are migraines. So there's this overlap between Chiari and migraine. And we'll talk about that, what some of the mechanisms could be that might explain that. So they looked at, this is just a meta-analysis that was published in 2023 in one of our journals, Cephalogist. That might not be something that you would read in the Chiari literature. But they looked at conservative management. They looked at extradural decompression, and they looked at intradural decompression. And this is percent improvement. So 0.2, 0.4, 0.6, 0.8, 1 is percent improvement in headaches. Now, I will tell you that this is not hard science. A lot of times they're just asking like a visual analog scale pre and post-op, or they'll give a pain severity rating pre and post-op. So this is not what in a headache clinic would be considered real high level evidence. But nevertheless, if you look at conservative measurement, they did both fixed and random effects models for the meta-analysis. And if you look at the two little kind of diamonds on the bottom, you can see that with conservative management, there's about a 60 to 70% improvement in both the fixed and random effects. Fixed is on top and the random effects is below. But you can see that when you start getting extradural versus intradural, you start getting levels of improvement that are much higher, well over 80%. And there might even be a slight increase in the intradural decompressions in terms of relieving these types of headaches too. These are of typical headaches. So those are the cough headaches, exertional headaches. Now, let's see here. Now, if you look at predictors of improvement in headache and Chiari disorders, a lot of it kind of makes you think that it relates to whether the obstruction of CSF flow has been improved by the Chiari decompression or not. So If the clinical predictors of headache resolution include if the headache was triggered by Valsalva maneuvers, if there was severe headache intensity pre-op, if the duration of the attack was less than 5 minutes, so kind of a classic Chiari headache, if it was occipital location as compared to frontal or temporal or parietal locations, and also if the number of headache days per month was actually greater. So those were all predictors of response. Now, the other thing that was interesting is this particular author looked at CSF obstruction and improvement in various clinical symptoms of Chiari. And they found that if the CSF obstruction was relieved with the Chiari decompression, that headache was more likely to be improved, basically. So, and you can see that if you look at the graph on the left where it shows headache, is there, percent improvement was higher if the CSF flow was improved, suggesting decreased obstruction by the Chiari decompression. Now, this whole conundrum so we talked about the classic case, but the reality is that oftentimes there's other types of headache disorders that can either occur with the classic Chiari headaches, and then what role does Chiari play in these headache disorders? So this was a case series also published in one of our journals, Cephalalgia, where they looked at the different types of primary headache disorders that occurred, primary and secondary headache disorders that occurred in patients with Chiari malformations in 65% of them. So about 41% of 65 patients in this Chiari clinic actually had headaches. Cough headache occurred in about half, 51%. Episodic migraine in this clinic, it was just 5%, but chronic migraine, which is what we see in a headache clinic, very, very common. 25% is a vast overrepresentation of chronic migraine. So that's where you have 15 or more days with headache, 15 more days with headache of any kind, of which 8 or more meet migraine criteria. But even episodic tension type headache was 12%, and chronic tension type headaches were 12% as well. So you can see that in this case, this Chiari clinic, that headache disorders are quite common, and particularly chronic migraine and tension type headaches as well. Now, if you look at what happens with the so-called typical versus atypical. So atypical includes the migraine and tension type headaches. Typical, once again, is the cough headache. And you look at what happens to the number of headache days. So this is looking at headache frequency, both pre and post-op after Chiari decompression. What you find is that it seems to go down. The typical headaches went from about 25 days per month down to about 5. And even the atypical headaches, the ones could be migraine or tension type headache, went from 20 days down to less than 5, down to about 4. So to me, this is really interesting, if you have patients that have Chiari decompression, might it not only improve those headaches that are typical, the typical cough headaches and exertional headaches, but could it improve also the primary headache disorder as well? And we'll talk about some potential mechanisms for that. But first, you have to know what a migraine actually is. These are the criteria for migraine without aura. It's made solely by history. So they have to have 2 of 4 clinical characteristics. It has to be unilateral, pulsating or throbbing, moderate to severe intensity, or worse with exertion. So 2 out of those 4. You have to have 1 of 2 associated symptoms, either photophobia and phonophobia, so sensitivity to light and noise, both of those, or as a grouping, nausea or vomiting. So 1 of those 2, and the duration has to be 4 to 72 hours. And there also or you can also have migraine with aura, which are, there's a variety of different types of auras, and those are diagnosed separately, but we can talk about that if someone wants to discuss that maybe in the Q&A. Now, there are a number of migraine meds. So when we're taking care of these headaches in these people, so we're saying, oh, well, you've got migraine, or you've got cough headache, or you got Chiari headache, and so forth. But we have a variety of different options to treat migraine headache, including anti-epileptic drugs, beta blockers, these things called CGRP monoclonals, which have kind of revolutionized the way that we treat migraine now. So they block a protein that's released from the trigeminal nerve during a migraine attack called CGRP. And there's a variety of ways to block it. There's a CGRP monoclonal, which are monoclonal antibodies or injections given either once a month or once every 3 months. But there's also something called GPANs, which block the CGRP receptor. These have revolutionized the way we treat headache patients, and many Chiari patients may actually end up on these meds. But there also are ARBs, candesartan, there's Anabot, which is anabotulinum toxin A, and that's level A evidence, and level B include things like amitriptyline, venlafaxine. So if you're seeing these Chiari patients in your clinic and they're seeing a headache doctor, it's not uncommon for them to be on one or more of these different meds to help manage their headaches. So let's talk about Pseudochiari. This is interesting. So intracranial hypotension, about 16% have tonsillar ectopia more than 5 millimeters. So, and then dural enhancement occurs in 83. I think most headache doctors would say that they would strongly recommend not doing Chiari decompression unless an MRI has been done with and without contrast to make sure there is no smooth dural enhancement. We'll show a picture of that in a minute. But likewise, intracranial hypertension, about 10 to 24% of the time in 2 different studies, found tonsillar ectopia. So from a headache standpoint, those are probably the 2 diagnoses I think we need to make sure do not coexist. Otherwise, we may be doing a decompression for the wrong reason. Diagnosis of intracranial hypertension requires papilledema, so swelling of the optic nerve, a normal neurologic exam except a 6-nerve palsy, normal neuroimaging of the head, normal CSF composition, and this an opening pressure greater than 25. That's the classic definition. But there now is something called intracranial hypertension without papilledema. So they may not have swelling of the optic nerves. And that can also complicate the picture as well. So if you have an opening pressure over 25, then they don't have papilledema. And particularly if they have signs on MRI of intracranial hypertension, things like an empty sella, a dilated perioptic nerve root sheaths, et cetera, the findings that you see with intracranial hypertension. Now, the other interesting thing, I think this relates to Chiari and why there could potentially be such a high incidence and prevalence of migraine in that population, is the fact that the headaches of intracranial hypertension resemble migraine. What we don't know is whether these intracranial hypertension patients have a genetic predisposition to migraine and they just kind of interact with one another, or whether the intracranial hypertension by itself can induce migraine-like headaches through increasing pressure and or volume within the dural sinuses, and which might activate the trigeminal nerve, which may cause pain. But in this study, either migraine or probable migraine, which is migraine missing one diagnostic criteria, occurred in about close to 70% of the patients. There's the locations of the headaches. You can see some of them overlap with headaches you would typically think in Chiari, in nuchal headaches, posterior headaches, and so forth. They have migraine-associated symptoms, and the headaches have classic features of high-pressure headaches. So headaches that are worse when you cough, headaches that are worse when you sneeze, headaches that are worse when you bear down, headaches that are worse when you lie down, headaches that wake you up in the middle of the night, headaches that you wake up with, headaches that are worse when you exert yourself, and so forth. So these are all high-pressure headaches. Many of these have overlapping features with Chiari headaches. So there tends to be this overlap between high-pressure headaches and migraine. And like I said before, we really don't know what's the horse and what's the cart. Does migraine, it coexist with intracranial hypertension and they just kind of feed off one another? Or the latter would be, could intracranial hypertension produce migraine-like headaches? And the more I see this, I think that that's distinctly possible. Now, the drugs that we use for intracranial hypertension are things like diuretics, and the big one would be acetazolamide. I use a lot of acetazolamide in patients with Chiari malformations. I'll often layer that into my migraine therapies if they have migraine-type headaches. Even in patients that have had decompressions that seem to have worsenings of headaches afterwards, sometimes I will give them a trial of acetazolamide to see if they improve. The other drug that we commonly use would be topiramate, which has been shown to decrease intracranial pressures within patients with intracranial hypertension as well. And I'll use that in Chiari patients as well. And there's a variety of procedures, optic nerve fenestration for visual, deterioration, various VP and ventricular peritoneal, lumboperitoneal shunts can be done as well when you fail medical management. There's even, interestingly, one study that suggested that one of the CGRP monoclonals was effective for treating headaches and intracranial hypertension. So once again, you can see the overlap between these syndromes. Now, these are the diagnostic criteria for intracranial hypotension. Typically, they have to have either one of the following, either a low opening pressure, less than 60 millimeters or 6 centimeters, improvement after epidural blood patching, demonstration of an active CSF leak or cranial imaging findings of intracranial hypotension. If you have smooth dural enhancement on the MRI, so that would be a migraine with and without contrast, it's pretty pathognomonic for an intracranial hypotension. So they usually have a CSF leak, or now what we're finding are these CSF venous fistulas that now account, they're basically fistulas between some of the paraspinal veins and the subarachnoid space. And that can account for up to 50% of all intracranial hypotension. So that's something that's new that we've been finding. What's interesting too is they are less likely to have dural enhancement than if they have a regular CSF leak, interestingly. This is an example of the smooth dural enhancement. You can look at image A. This is a picture or a film or a slide that was given to me by Linda Gray as compared to nodular. If there's nodular dural enhancement, then that's not likely intracranial hypotension as other disorders like tumors, sarcoidosis, and so forth. There is one study that looked at imaging findings to see if they could differentiate between intracranial hypotension and Chiari malformations. And they found that they were looking at a couple of things, the slope of the third ventricle. If it was less than negative 15, at least in this study, it had a sensitivity and specificity over 100. The pontomesencephalic angle, if that was less than 45 degrees, that also had 100% sensitivity and specificity. So there at least is one imaging study to suggest that you might be able to distinguish between these two disorders by neuroimaging findings. What about headaches after? This is another problem, is that so patients will have their Chiari malformation. Sometimes their headaches improve, and then 6 months or 12 months or 2 years or 5 years later, they tend to worsen. And this is a pediatric study that was published in 2008. The top graph is the recurrence of symptoms up to 80 months after Chiari decompression. And you can see that headache returns in about 40%. So then the question comes up is what's going on? What is causing the headaches to worsen after the Chiari decompression? One, they could have a pseudomeningocele. Two, they could have failed to relieve the obstruction with the initial surgery. And then this kind of plays into some of this arachnoiditis discussion that was discussed earlier, is could there be extradural or intradural adhesions obstructing CSF flow? And I'd be curious to see how you guys think that would be detected. I mean, we often do just a cine MRI, but I often wonder whether that's really sensitive enough to pick up something like that. But maybe that's something I might ask you guys. Cervicogenic, there could be a craniocervical instability complicating things. Or they could, in some instances, have Chiari, Pseudochiari with either intracranial hypo or hypertension. I mean, I had one patient that underwent a Chiari decompression, and then about 3 or 4 years ago, or 3 or 4 years later, started developing some orthostatic headaches. And, she ended up having a CSF leak, and we repaired that, and she was fine. And I always kind of wondered, whether that diagnosis had either been missed preoperatively or whether somehow the decompression might have predisposed to a CSF leak. It was just, or maybe they have a connective tissue problem like we've discussed, and maybe that's kind of the unifying factor, the feature that might explain those two things. So it's interesting how all these things kind of interrelate. So in conclusion, headache is the most common symptom reported in Chiari patients. Tonsillar ectopia does not by itself establish a Chiari disorder, particularly if they've got intracranial hypo or hypertension. A headache attributed to Chiari malformations tend to be localized to the suboccipital-occipital location, last for minutes, and occur with Valsalva, coughing, or exertion, although primary headache disorders like migraine and tension-type headache are also very common in Chiari patients. And Chiari decompression can improve headaches in selected patient populations. And I'll be also curious to find out what your guys' vantage point is. If a headache was particularly disabling, would that be a symptom that would lead to a Chiari decompression if they didn't have other signs, other indications for the disorder? Thank you very much.